Right. Okay. Okay. Right.
All right. Good morning, everyone, and welcome to NB Heart Center CV Weekly Rounds. I'm really excited today to have a colleague and a friend, Dr. James French from the Department of Emergency Medicine, speak to us. James has a lot of areas of interest since he has joined us here at the St. John Regional Hospital. He's an academician, he's a clinician, but simulation has been one of those things that he's really championed over the years, and I've seen him present at the Dragon's Den, as well as at other symposiums. And really, I've always been super impressed by the emergency department and their use of simulation to really practice process and to perfect process. And I thought it would be neat to kind of speak to that today. It's something that at the Heart Center we've talked about a lot, but never really kind of lifted off the ground as a formal process. And I'd love to kind of see that, be something that we can take on. So without further ado, let me introduce Dr. James French and look forward to hearing your talk.
Thanks, Ansar. Yeah, that's a very kind introduction. So I think simulation really isn't something that's optional anymore. If you look at really any high performing industry, when it comes to education or prototyping or developing process, there is something. In medicine, that's really just been meetings. And really that just isn't adequate. There's enough evidence now to say that this is something that really all safety critical areas of the hospital should be using in some form for some reason. So I've been involved in simulation since 2003. That top left picture is a very young looking me learning to be a roadside intensive care physician on an air ambulance. And then the top right picture, I started training that faculty in 2004, and then was involved with the development and fitting out of a trauma center in Cambridge University Hospital in England. We used simulation for that. And then when I moved here, started providing outreach simulation to the small hospitals in Zone 2, and then got a job setting up the simulation program for the province. With the trauma program, we started off with 6 faculty. When I left, we had 28. And we were running high fidelity simulations in 13 different hospitals. So that's something I'm pretty proud of. When we think about simulation and medical education in general, the thing that we tended to sort of focus on is the green box in the bottom left-hand corner, which is the patient. So we went to medical school, we learned about diagnosis and treatment and pathology. The thing that simulation makes you focus on a lot more, and I think this is entirely appropriate, is the blue box, which is how you as an individual react to high risk situations. That's very relevant to emergency medicine. We can't become victims of our own fear biology in those situations. We have to be able to keep our cool. And then managing the team. If you don't manage the team, then nothing really gets done. And then the other thing we're going to discuss today, probably in a bit more detail, is the sort of yellow box, which is the environment and systems. And when you do simulation, what you find is that the feedback after cases is, I would say, it's 80% a mixture of self-management, team management, environment management, and systems, and then 20% medicine. It really brings out the other aspects of care that you wouldn't otherwise get a chance to consider, discuss, and analyze in a sort of cool way. So I'm going to start with a case. It's a real case. This girl came into the emergency room for various reasons. She'd injected the right side of her neck with crack cocaine and Dilaudid. She goes to triage, ends up in a room. Tushar, Dr. Pisha actually saw her, and then very quickly realized there was an expanding lump getting bigger and bigger on the right side of her neck. He sat down next to me and said, if this girl gets sicker, she's going to be what we call a double setup. If she needs to go to sleep, she's going to need intubation from the top and potentially surgical airway. And then sort of fast forward, I don't know, 5 minutes, she's now hypoxic, agitated, blue. This lump is occluding her asphyxia. So I had to kind of plan for a surgical airway. We did a rock, paper, scissors, and I got the surgical airway. And I looked in our airway cart that's been very expertly designed. And there's this thing. This is the Cook Emergency Airway Kit. It's got 12 pieces of equipment in it. And the pieces of equipment are for a kind of a 5-step approach with, you can see the true soda later and keel hook. and also the Melker approach, which is a kind of a wire. I didn't do any of those things. I use a scalpel, a Mark 1 finger, and a bougie and a tube. So of these 12 bits, I actually only used 2. And then what happened was, because there was stuff I needed, I had to run around the emergency department trying to find things. And this is a video of what that looks like. So this was actually done in Toronto. They put motion trackers on people, and a very similar situation of the staff trying to find equipment. And I then spent the next sort of 5 minutes trying to find other things that just weren't in that drawer, because as physicians and teams, we don't often think about all the other things you need. And that's kind of what I looked at, is like a sort of like a high-speed snail trail running around the department trying to get the stuff I needed to complete the procedure. So anyway, decide scalpel finger bougie, longitudinal cut through the skin, horizontal cut to the membrane, and put my finger through the hole, could feel the trachea. The trachea feels different, but the trachea down, put this bougie down the side of the hole, and then the tube over the bougie. And when as soon as the bougie really went through and I really opened up the space, there was a big rush of air. And I thought, oh great, she's not going to die. She's going to be fine. This is amazing. This poor woman is going to survive. And then the next thing I felt was absolute abject terror and fear. And I thought about, my kids. And the reason why I did that was because she's got HIV, she's got hepatitis C. She exhaled a shower of blood, mucus straight into my eyes and my mouth. And the reason why I was scared, because the one thing that I forgot was one of those. And the reason why I forgot one of those isn't because I'm an idiot. It's because of this thing called Miller's Law. And Miller's Law says under certain situations, you have a bandwidth. You can think of between 3 and 5 things at any one time. And I just wasn't thinking about me. I was thinking about doing the procedure. And because everything wasn't together, the thing that I'd forgotten was the thing that keeps me safe. And then I had to have PEP and a whole load of blood tests to make sure I didn't have HIV. And I don't, fortunately, but that was a pretty scary time. So the first rule of this is simulation allows you to get everything together that you need. If you've got to do a sudden, unforeseen, high-risk procedure like surgical airway, or maybe you guys are thoracotomy on your ward, you don't want to be running around for this stuff, because it's safety critical. You want to be thinking about the procedure, not about the logistics of getting everything into one spot. Lean methodology, which comes from Toyota, is around. One of the phrases they have is, what plays together stays together. Obviously it's used in very successful industries like the Toyota car company. To get everything together, you need to know what you need, and to know what you need, you need to learn to process map. And process mapping is essentially every time your hand moves and does something, that is a step. And when your hand moves and does something, you write down a square. You write down what you've done on a square Post-it note orientated normally. And every time you make a decision, you write down what the decision is, and you do that on a Post-it note that's angled through 45 degrees, that's you write the decision down. And the first thing you're going to think of is, I'm not going to do that. Well, what I would say is, you don't have to, right? If you do cases, which you all do, then video one of them and get someone else to do it for you, or video a simulation. We all have GoPros. Ansar's always videoing himself. He's a bit of a film star, so I'm sure he's got some video equipment he could lend you, and you can video this. You can video one of the things you want to do high risk happening, and then you can get someone else to process map it for you. Say a medical student or a resident, someone who wants a project to do, assisted by an administrator. And when you actually process map surgical airway, for example, I didn't just need 2 bits of equipment. I needed 26 bits of equipment. And that's pretty typical when we actually go through these things in detail. There's a lot more stuff you need than you think for a high-risk procedure. The only problem with that is, when you get all this stuff together, you've got this kind of safari of bits of equipment in a pile, and it's hard to find the things you need straight away or in stages. So the next thing you need to do is you need to divide the equipment you have, or the thing that we've done is we've divided the equipment we've had into things we need to guarantee our safety, things we need right now. The first thing I need to do, the first thing I need to grab, we call it the stat pack. I have heard Chris White call that the satellite pack. And then we throw everything else in a bag that we go for things we can use later on. And how that looks is everything's very clearly labeled. This is one of the labels for the surgical airway, so we don't have another critical event. Doctor, this is the first one. This is on the top. Doctor, put on your face shield, gloves, and gown, protect yourself. And then the second pack is kind of instruments. Everything with a big green label in our department is the thing you open first. It's kind of uniform throughout. Well, it's getting uniform throughout. You open that equipment first, and so if that was a surgical airway, it'd be scalpel, finger, bougie, a marker. If it was a chest tube, for example, it would be the scalpel, Kelly's, other sort of safety critical immediate bits of instruments. And then the last pack, the blue one, is everything you need to kind of complete and secure the tube, or complete whatever procedure it is. One of my pet peeves is this is a patient table. There is at least an 80% chance in the last half hour that patient table would have had a urine sample on it or a pot with some people's dentures in it. And unfortunately, I've done every single life-saving procedure you can think of in an emergency department from a patient table, which is frankly bullshit. That is not adequate or acceptable. You wouldn't do it in an operating room. When we look at this team of people who are doing a life-saving procedure to unblock a large vessel occlusion in someone's cerebral vasculature, they're not thinking, oh shit, I know what I need now. I really need that bedside table just to make things better. You need an adequate system for equipment and logistics. This is the system that I designed for, or a team of us designed for Adam Brooks Hospital, Cambridge, where everything we need for critical procedures is in a tower, and everything's very clearly labeled. When you want to do a procedure, you remove one of those drawers. The labels, as I said, are very clear. The QR code on the left is education material. The QR code on the right is suggestions or things that are missing. And then you put that into a generic procedures cart. The bottom of the cart there is gloves, gowns, things you need to keep yourself safe, sterile things, things you might need again, like extra drapes, local. And then you put the drawer in the cart, and then when you finish with it, you just take it out and you put it in the out rack, and then the logistics team or the EVS team come out and stock it up for you again. And that's a Kanban system, that kind of way you move equipment through a system, and that's part of, again, major industry. In a lot of these procedures, there's a lot to think about. There's this phrase called cognitive offloading. Cognitive offloading is you want to really only be thinking about the things that are important. Obviously, having everything in one place means you don't have to run finding it. That is a form of cognitive offloading. But if there were things that you could do, like aid memoirs, things that would help. And one of the other things that process mapping allows you to do is it gives you a list of all the steps you need for procedures. And then what you can do is you can send that list of procedures to your colleagues, and you can decide as a group what the most important ones are, and you can add that to a checklist if you want. So this is a procedure label memoir for a checklist. What I often do is I run through that before I do it. The yellow fields are the ones we do get the nurses to read out, which is the steps 8, 9, and 10. They relate to the Provenance study on actually central line sepsis, but we use that challenge response system of sterility for all invasive procedures. On the left, you can see the multicolored box, which is sort of size-based interventions we need to do for kids according to the Broslow-Luton system. In this case, chest tubes, so the tube size, lidocaine dose, ketamine, and fentanyl, so that we don't have to think about it, we can just look. And then on the right, there's bottom right, you'll see indications for emergency thoracotomy and emergency or urgent thoracotomy. This is the checklist we use for rapid sequence induction. When we studied this, it reduces safety critical errors by about 50%, catches errors mainly of omission and some errors of commission. And then when we're preparing, for example, for an airway intervention, because we have the list of equipment that we need, we have got a kit dump, which is a photo that goes on top of the airway cart. So if you need the equipment in a hurry, you just fill out that silhouette, and then you know you have everything to hand that you would need for a safety critical procedure. We know equipment problems probably complicate. When you look at big area registers, about 30% of advanced airway management, so it's important. So that's kind of equipment and other stuff. The next thing is skills. So if you look at people who learn really complex things, some of the symphonies can be, a number of different movements. It can go on for an hour. There's multiple different parts of music that people have to learn completely by heart. And when you look at how musicians do that, they will take the whole piece of music and they will start learning in chunks. And then they'll practice the whole song all the way through, and then they'll practice as a group or as an orchestra. And that's skill. And now if you've done this process mapping thing, then a couple of other things fall out of it. So microskills training is, if you have a whole list of steps that you've derived for a procedure, you can use that to teach someone how to do the procedure. And so what you do is you do it in groups of 3. You have the person doing the procedure, the assistant, and you have the person with the kind of a list of steps. person reads out a step, and then the person does the procedure with the assistant. And then you talk about it and you change around. And it's a slow tempo. It's that each time you do a step, there's coaching, and it's very good for psychomotor skills and for equipment and understanding the flow of a procedure. But it is slow. It's not real time. So once you've got it, you then do this thing called rapid cycle deliberate practice, where you keep doing that skill over and over and over and over and over again in a kind of short scenario, just to get better and better and better and better until you can't fail. And then once you've done that, you then move it into simulation, and simulation being full scenario with a full team, and that skill will be part of an overall case. And is any of this worthwhile? Does any of it work? Well, yes, it does. So I just picked this one study that shows that if you do regular simulation and you have a cardiac arrest on the ward, then you're less likely to die. Other news, regular simulation means less nurses leave. Pretty topical at the moment. If you do regular simulation, people are more resilient to high risk, very stressful situations. We know that it reduces errors, it increases adherence to hospital policy and SOPs, and is all around very positive. The downside of simulation is it's resource critical. And if you're going to start something up, what I would do is suggest you getting into bed with another department that does it regularly, and set up a collaborative project to do something as a kind of a start. And for example, the emergency department, we need to sort out our thoracotomy system because it's a bit of a mess. So maybe together we could work on a unified thoracotomy process. So you guys can do it on the ward, we can do it in the emergency department. Everyone knows everything is. It's all standardized. Everyone's happy. It's good to go. So just writing down the menu of steps. First thing is assemble a representative team for either simulation or equipment or even skills sort of development projects. Put it in a project management infrastructure because there's a lot of steps, there's a lot of moving parts. And then as a group define what is the need, what is the scope of what you want to do, what do you want to achieve. And then process map the thing you want to improve, either by videoing a real case or videoing a simulation. And then look at that and then tabletop the possible solutions and things that you can improve from that. Come up with a prototype and then you test it with simulation. That's important. And then it allows you to iron out the kinks. Finalize the solution, develop a learning package. Because simulation, you still need the knowledge element, you still need the skills training package, and then you need simulation. And then you roll it out. And that's it. So if there's any questions, I'll stop sharing so I can see people.
Perfect.
That's it. What's the time? Oh, great. 20 past. Perfect.
Right on.
I just wanted to get it.
You know what? It's a good thing you practiced that talk. That's why you got it nailed under 20 minutes. Yeah. Thanks so much, James. Well, I'll open it up for questions. I think there's a lot of interest in simulation within the Heart Center. Specifically, I can speak to the surgical side of things. I know that we've had numerous kind of instances where we have thought, if we could have simulated that, we would have probably done that better, whether it be opening chests up on the floor to doing lines in the ICU. I would say even initiating ECMO in an emergent fashion. This is especially prior to Chris having arrived. I just really think of it from the standpoint of doing something as simple as, line insertion in the ICU, which is something that, I'm doing less and less of because I pass it off to interventional radiology and they kind of take care of it. So when I'm kind of the one doing the central line or the ARG line, it is a schmoz from, as you said, from just basic safety and wearing the right, gown and gloves and face shield and all of the above. It's gotten a little bit better thanks to COVID, to then going through the process of identifying what it is that I need to do the procedure and then having the nurses be able to identify those things. And I think it's just by virtue of the fact that nobody does it very often that when we do it, it's a bit of a mess. What has been your approach? Did you sort of start small and then kind of ratchet it up in the emerge?
You doing things rarely and it being a bit of a schmoz, to use your word. You just described the specialty of emergency medicine, right? So, our challenge is currency because we have to be able to do everything, but we're masters of nothing, frankly. So we have to have that backup approach where the system really supports you, where a true clinical governance system, so we can do things regularly. And yeah, I would, you can start small. So if you could start with like line insertion, we've already done a lot of work on central line insertion. Very happy to share all that with you. but once you've done it once, you'll get it. I mean, once you've gone through the challenge is setting up the team and having some project management and having the videoing the procedure and then process mapping. And once you've done it once, I think it would be pretty straightforward. Then you could look at something much more complex than like ECMO. But yeah, start small, something achievable, get a win. It's all publishable, by the way. So if you want to, you can publish like the process map or the kind of the quality improvement that you've done through this, and you can publish that in different journals. Yeah.
I'm just gonna Chris, go ahead, and then JF.
Thank you for your talk. I mean, we've had many conversations about this, but I think, as already pointed out, our specialty is ripe with opportunities to improve process in the ICU, the ward, and in the emergency department. And I think we are really excited to continue to work together to, optimize our pathways for these kind of emergent procedures. And I think, the most recent ECMO cannulation last week was a good example of that. Like, I think we, had not really thought about how the patient being in the COVID isolation room was going to impact our process. And, I think as we move forward, we really look forward to working with you to do some high fidelity simulations, which I think what we learned through that ECMO process, we can then, spill over into opening chests on the ward and the ICU, as you said, and even other things we do in the operating room. So, we look forward to learning from your expertise in this area.
Yeah, thanks. And right back at you, by the way. And what I'd say is that, the one drawback is it's a bit of a process, right? The whole thing. So it's not a quick fix. It's a solution, and that's going to take, I would say, even for something like central line, 3 months. For something like thoracotomy, probably 4 months. Something like ECMO, probably 6 months. If you have a good project management cadence, regular meetings, because there's a lot to it. It's things like, okay, so we've decided this is what we need. It's going to go in these sub packs, and we're going to stage these sub packs this way for ECMO, for example, because we've decided that's the sensible way to do it. Well, who's going to put that together? It's probably going to be one of your stores people. So what's the logistic process for ordering your equipment? And okay, then it goes in this thing. How is it cleaned? Just all that stuff that if you don't think about up front, it kind of bites you in the ass when it comes to doing it. So I don't want to put you on. It's definitely a worthwhile thing to do, but it's not something you can do over a weekend. It's gonna take a team, and it's gonna take a bit of effort.
Yeah, JF.
Yeah, I was going to make the comment that in my mind, the only way to guarantee that you're going to do this and do this regularly and all the time is actually to make this part of our regular routine. Like we have these rounds every Wednesday. Why not one of these rounds every month is a dedicated slot where you're going to rehearse something? It is, in my mind, the only way we're going to change. Because if we added to the pile of other things I need to do and the pile of things that Chris has got to do, we're never going to make this.
Perfect.
Anyways, that's my bias.
On. That's absolutely bang on. And it's that setting up a simulation program is another thing, and it's on top of your burgeoning workload is not sustainable. Replacing something that's of lower value is probably the way to go. And what you just said is right. So that's what we do. We have our rounds. We replace a couple of our rounds for skills and cadaver training and everything else. We're lucky that part of our AFP is simulation and education. So we have a session probably at least every week for some group in simulation on department. So, but yeah, that would be a good way to start. And if you said to the emergency department, we want to use your space to work out how we're going to put lines in, or do some simulations of the lines, and we want to start doing it on a regular basis. The quid pro quo is that we get to develop good, solutions for chest tubes and line access and thoracotomy in our department and ECMO. Then they're going to say yes, right? They are. Yeah, that's a good idea. Yeah.
And maybe just to follow up on that line of thinking a little bit, I think JF identified the opportunity of maybe even dedicating 1 out of every 4 of these rounds to just that sheer act. I was going to ask, I mean, one of the problems that we always have with this, I remember we did a simulation exercise around opening the chest in the ICU. That's how we streamlined our cart. The OR actually is probably the most, simulatable area, avenue, because the nurses are already thinking in that manner. There's a lot of repetitive motion, and they're just very good at just, they don't even think as they're kind of sometimes doing these things. But my question is, how do you make sure that you can get all of the staff that you need to get in on these things? Because oftentimes it falls outside of payable hours, right? I mean, we just, that is one of the problems that we've always had, is how do you get people to come in on their off time? Do you pay them? Is there a bank of dollars put aside to say that, we're going to, as part of this is considered education or continuing education, and there's credit for it? Like I'm speaking obviously specifically about nursing, but also just about physicians and other allied healthcare professionals.
So I'm going to say we haven't really cracked that yet. The way we've done it in the past is cracked, no pun intended. The way we've done it, the way we've done it in the past is basically beg, borrowing, and stealing, and trying to show overlap. So, or trying to show opportunity that's cost neutral. So, beg, borrowing, and stealing. We've got a small fund, an AMA fund that's not a lot of money, but what we sometimes do is, we'll hold, for example, the Gadaver Day, which is, we call it the cyborg, where you train on cadavers and simulation and skills trainers. We pay the nurses out of the fund. A lot of the nurses come in voluntarily, which is amazing. And sometimes our nurse manager can find small pots of money to pay people. And sometimes we don't have nursing available and we have to cancel simulations, being the reality. So what I would say is buy-in is where it starts, and showing people that you have good relationships with in positions of authority in nursing, that this is safety critical, would be the way to start. I think just getting buy-in with senior nursing leadership in your department, and then buy-in from the nurses in general.
Well, and one of the things, and just to add to that, we do have a robust, clinical instructor / education program here already for the nurses. Sue Morris, I don't know if she's on the line.
Oh, yeah.
She's somebody who champions this, and Reno just sort of mentioned to me that there are education days built in for nurses for ACLS and CPR. So maybe this is something that we start to look at, as being a part of the program, is how do we build this in so that we can incorporate simulation. And like you said, I mean, central line, if that's going to take 3 months, and say ECMO more like 5 months, well, guess what? You're not going to tackle 15 things over the course of the next year. You've got to find the 2 or 3 things that you feel are the most, I guess, problematic and technically the most reproducible, and just go for it.
And you can engage a lot of the kind of horizon management hierarchy or systems. That this falls under risk management. This is a risk management kind of panacea. It falls under education, it falls under staff retention, HR, it falls under wellness because it increases your resilience. So there's a lot of things that it hits, and you want to kind of make as much noise about that as possible, and say this is what we're doing it. Maybe start as a pilot, say we're going to do a pilot, we're going to evaluate the pilots, that's a good kind of way of framing it. And then you've got an opportunity for a stop point, and then to write up that experience and then send it to all those different people and publish it, and say, actually, this is something we need to do. And the other thing I'd say is that, like innovation funds, this would be something that's highly amenable to certain grants as well. And so maybe it's, you start with a pilot, you beg, borrow, and steal like we had to do, and then you look for funding from organizations. I mean, maybe that's a way to go.
Yeah, that's fantastic. And as part of even just using ECMO as the base for that, Chris, and just applying for granting around that, I think is a huge opportunity. All right. Well, look, on that note, I'm going to thank you so much for your time, James. I think once again, we can talk simulation, but I think this is a whole different level of enlightenment, and we appreciate that. Thank you, and look forward to collaborating with you guys down the road.
Yeah, and thanks for your involvement with the high-risk cases recently that we've had. You've all been very supportive and immediate to respond, and great colleagues, and thanks a lot.
Thanks. Next week, Dr. Paul Atkinson, speaking of emergency department physicians with collaborative capabilities, who's going to speak to us about research in not only at St. John, but in the province of New Brunswick. Thank you so much. We'll see you guys next week.
If Paul's coming, you should bring a pillow and a coffee.
Will do. Consider it done.
Those boring.
Thanks so much.
Bye.
Bye.